what is your vision for the future, specifically kind of thinking about health centers and how they fit into that bigger picture?
We have in this country created a de facto right to health care in the emergency room.
The financial solvency and the future of the health center program, and even just thinking about systemic change, I'd love to hear your thoughts around investment in health centers.
I think we've put substantial resources into standing up and supporting health centers as infrastructure.
Today, we're taking a step back to look at the bigger picture and some bold ideas about where community health centers fit into the future of America's healthcare system. We know health centers are on the front lines, delivering primary and preventive care to millions of people who might otherwise go without. But as the nation debates the future of Medicaid, coverage reform, and market-based solutions, the question is, how do health centers adapt, thrive, and continue to serve their communities? I'm so pleased to be joined by a guest who spends a lot of time thinking about these issues from a policy and systems perspective, Ed Haislmaier from the Heritage Foundation. Together, we'll explore common sense approaches to policy for healthcare safety, for the healthcare safety net, and what it could mean for community health centers. It's a great conversation, and I'm really excited to dig in. Well, hi everyone, I'm Amanda Pears Kelly. I'm the CEO of Advocates for Community Health, and this is Community Health Centers Unfiltered. I'm really excited for our guest today and for the conversation. Ed Haislmaier with the Heritage Foundation is with us today to have A to Z on sort of where we are with all of the things happening in the healthcare space, but specifically in terms of the lens that Heritage brings and the role of health centers and sort of what we can expect going forward and ideas for how we can work together. So Ed, while we get into this, before we jump into this conversation, can you introduce yourself for me?
Well, hi, I'm Senior Fellow in Health Policy here at the Heritage Foundation. And I've been doing health policy for, over 30 years now. So I can't say that I'm an expert in everything, but I've had a very interesting ride in learning all sorts of things about the nooks and crannies of health system in this country.
Yeah, I know you've been at it for a long time, and with that time comes wisdom. So we're really grateful to be able to talk with you today. Before we dive into questions, though, can you just give kind of the top-level explanation of what is Heritage? I feel like you guys are everywhere and such a common name, but I don't know that people really have a great understanding of it.
Heritage is commonly called a think tank. The joke that I have is, as I like to say, I get paid to give Congress gratuitous advice. They may or may not take it. So what we're doing is primarily looking at crafting public policy solutions. And so you're considering issues or problems and saying, well, what do we recommend that they do? And it's not just Congress, though that's our principal audience. It could be the executive branch in the case of rulemaking. It could be states. So, for example, my colleagues who do a lot of work on education policy, most education policy is at the state level. So a lot of their focus is on governors and state legislators saying, what should you do to improve your educational system?
Got it.
So that's what we're doing. I mean, we do have a lobbying arm now. We didn't used to until 2010. We do now have a lobbying arm, but it's principally about putting the ideas and the recommendations out there. And I like to think that we can sort of take a step back from a lot of the day-to-day that goes on, particularly with the interest groups lobbying, and take a broader picture. At least that's what I try to do on healthcare.
Thank you. That's super helpful. And I feel like, Heritage has been a very recognized name for so long, just in terms of the recommendations and the ideas that come out of your shop. But I appreciate you giving it a little bit more color and context. So with that, let's dive in, because there is a lot going on in healthcare, and I'm really eager to hear from you specifically about the role you think health centers play in healthcare right now, and what do you think the future holds, or what is your vision for the future, specifically kind of thinking about health centers and how they fit into that bigger picture?
Right. Well, first of all, I think it's important to understand we're approaching the health system from the perspective of, is this providing what patients need? Is it providing good value for patients and consumers? I mean, because you could be a consumer without being a patient. You might be buying insurance, but not at the doctor's office, for example. The criticism that we have of the system is that too much of this is oriented towards other interest groups, less so to patients, and we can get into that. Within that context, you have the supply side and the demand side, if you will. And a lot of what goes on in health policy is focused on the demand side, which is really all about payment and who's covered and insured and all of that. The supply side is really where health centers, I think, come in, because they are part of the supply side and they are a particular solution in many areas. So, for example, if you have an area with limited provider availability because it's just rural or for whatever reason, then health centers play an important role in that. So we view them as part of the supply side, at least I do. And what we're looking at is ensuring that essentially there's a level playing field. A lot of times, I think, in health centers are a good example of this. The system is tilted towards one group of providers versus another group of providers. We see that, for example, in a current debate right now over site-neutral payment for Medicare for practices like oncology, where the way the reimbursement system works is it sort of favors hospitals' in-house operation as opposed to freestanding oncology centers. And so the argument has been, well, no, they ought to be reimbursed the same. Mm-hmm. So again, that's one of the things that we look at is, we don't think there's one particular solution, but we are, because we think that the market and private actors will innovate much better than government. So we're not looking to impose a top-down solution. What we are looking at is the government being even-handed? And in some cases, yes, the government does need to step in and help because of unique circumstances.
Well, it's interesting. I'm gonna take us off questions a little bit here, but I think that's an interesting call out because I think health centers sort of represent that really beautifully, and I'd love your thoughts on it. But to me, it's this wonderful hybrid of government oversight and investment, of course, and framework around, okay, this is what, at minimum, this is what it needs to look like. But I think because of the consumer majority board and because of where they are located, health centers are this really wonderful melding of actually addressing the community needs because of that consumer majority board, and having insight into what is actually happening on the ground with the help and the oversight and the support of government. But I mean, as you know, health centers need support and resources to be able to do that. But does that resonate with you in terms of how you just described it?
Oh, yeah. No, it does.
I want to take us to Medicaid a little bit and Medicaid reform.
Sure.
It's obviously top of mind for all of us right now. But from your perspective, what are the challenges and the opportunities for health centers in the context of what's happening right now with Medicaid reform?
Well, the Medicaid reform, and this is the legislation that was just passed in the most recent reconciliation bill. The Medicaid reform is not so much a system reform. We have some ideas for system reform. What it was really focused on was two things. One, it was focused, well, three maybe. One, it was focused on removing some fraudulent or opportunities for fraud in there. Two, and this is probably the biggest focus, was on rebalancing the federal-state share. The problem that from the federal government perspective is that states have been using financing games to really not live up to their share of the bargain and to try to shift costs onto the federal government. So all of the things about provider taxes and designated payments and whatnot, it really is, it's not about who's eligible, it's not about the services, it's not about the providers, it's about the state financing gimmicks. And that's still going to be contentious going forward, and it has been for decades. I mean, we saw this in previous administrations, including Democrat ones. I mean, the Obama administration actually proposed blending and lowering match rates to adjust. So that's an issue that I think is going to be in Congress for a while. The third point is that it was addressing coverage of non-citizens on the program or non-legal residents. That was part of what was in there. So in terms of removing people from the rolls, no, it wasn't really changing the eligibility criteria or anything like that. Now, the providers are upset because they were relying on some, and particularly by providers, I mean hospitals, because they were essentially relying on these provider games to manipulate reimbursement. So that's where you see the pushback. Now, in terms of reform, I think there are a lot of things that could be done, but you have to start by recognizing that Medicaid really has two fundamentally very different populations. One are people who are generally like the rest of the population and need some kind of acute care health insurance. It's just that they are low income. So these are the classic low-income children, low-income pregnant women, parents, things like that. The other group are the people who need things that are not provided generally by either public or private acute care insurance. These are people who need long-term services and supports. So, for example, most of the elderly on there, yes, some of them are getting some assistance through Medicaid in covering their Medicare copays for their acute care, but the real cost is the ones who need long-term services support because of things like dementia. You're also looking at the severely disabled population. So those are two different populations. In the case of the people who are non-elderly and non-disabled, those people can be transitioned into having more choice, both in terms of financing. For example, they could buy into, if you made reforms to the program, buying into employer plans, things like that, and also in terms of delivery. And I think a lot of those people wind up in certain areas being patients of community health centers, and that's certainly where community health centers get a lot of reimbursement from.
Yeah, I mean, I'll chime in and just sort of reflect a little bit on our patient population, and I think the importance of Medicaid to that patient population, but also to health centers in general. And then I'd love to kind of hear your thoughts on it. You know, health centers are serving almost 34 million people at this point. But it continues to be that 90% of those patients are at or below 200% of federal poverty. So to your point, these are individuals who do not necessarily have the resources to purchase private insurance. They need the support. Right. The other reality and really important part for health centers, as you know, is that, number one, they're going to see patients regardless of their ability to pay or their insurance status. So they are there. They are the safety net. But I think for patients that are covered by Medicaid, the importance of the reimbursement rate that comes from that in terms of predictability and financial solvency for the health center is vitally important. And the investment in the health center program, as you know, on the grant side, discretionary and mandatory, hasn't kept pace with need, and it really hasn't adjusted when you take into account things like just the cost, the continued cost. Mm-hmm. And so, you know, good, bad, and different, the changes that are going to take place as a result of H.R. 1 through this reform effort is going to have a pretty significant impact on health centers. They will continue to see patients, but if they don't receive additional resources and support in order to do that, it's going to look like, sadly, it's going to look like services being dialed back. It could look like sites being closed. It could look like doors being closed. And it has nothing to do with need. And frankly, it doesn't have a lot to do with commentary on the changes to the Medicaid program. It's just the reality that health centers find themselves in. So I'm curious, in terms of the changes that are happening and the role that health centers play and will continue to play in caring for that population specifically, Do you see those challenges, but also do you see opportunities for health centers to lean in, or that there be additional policy or resources allocated to support them in the process?
Yeah, well, first of all, the Medicaid rates are set at the state level. So right. There's a significant state component, and there's significant variation among states. So that's one place. And secondly, what you have, and the health centers are part of this, overall, is this issue of how do you move what is essentially a hospital-centric system to a more primary care-oriented system. And this is a bigger issue that cuts across both public and private programs, and residencies, graduate medical education, how the funding operates. I mean, if you look at, for example, some of the extra money in the supplemental payments that states are doing, and the federal government partly underwrites, and I've written about reforming this. It's very hospital-centric. And if somebody on the outside is a health services researcher, and again, this is not just conservatives, liberals, I mean, anybody in this area is pretty aware of the fact that we have a system that's overly hospital-centric. Mm-hmm. And so it does need to be a realignment. To the extent that health centers, community health centers are part of that, yes, I think they have a very positive role to play. The other thing that's very interesting, and we see this right now going on in the debate about the extra COVID subsidies for the ACA, is when you look at that population below 200% of poverty, that population it's difficult to get them insured either publicly. I mean, their take-up rates of Medicaid are, and we've had this for years, are less than one would expect. Mm-hmm. I mean, you're offering them essentially free insurance, and people aren't taking it up. Well, why is that? And we've seen this problem with the ACA subsidies as well. And the thing is, we have in this country created a de facto right to health care in the emergency room. Mm. And by doing that, we have inadvertently diminished the incentives for low-income people to take up the offer to get coverage or to use a less costly provider. So on the one hand, you don't have in this country the horror stories you have in other countries like Canada or Britain with, people just waiting in the halls on a gurney and never getting seen, or being turned away from the ER. I mean, we used to have that. That's how we got EMTAL, and, you don't see that anymore. So on the one hand, we solved that problem. On the other hand, though, we have to look and say, well, what are the incentives for those people to actually sign up? This is part of why I would move the existing funding for indigent care, and my colleague and I wrote a whole paper about this last year. I would move the existing funding from indigent care from the current system where it's handed out to states who then hand it out to hospitals, which may or may not be providing it, into something that is a claims-based system. If somebody shows up and can't pay, okay, go ahead and treat them and submit a claim, and we'll put the money in a pool. And eventually, as I've argued in the paper, you start with the hospitals, but then you could open that up to the clinics as well. And the advantage of doing that is also you would identify people who are eligible for these programs, mm-hmm. but not enrolled, and you could enroll them. So there's a lot that could be done to improve that situation. And I would argue that there's plenty of money available already in the system. It's just a question of targeting it. And again, you read the government analysis of this, whether it's the Medicare and CHIP Payment Advisory Commission, the Medicare Advisory Commission, Payment Advisory Commission, the General or the Government Accountability Office, all these studies, and they say, this stuff is really poorly targeted.
Well, and I'll be the first one to say, we would love to see more of that targeted funding go to health centers. They've proven the savings. They've proven to be able to, care for this very complex population. But I do want to lean into, because I know that Heritage really emphasizes market-driven reforms. And I would love for you to, one, sort of help our audience understand how these apply, and specifically how they apply to strengthening health centers and the, primary care delivery as a whole.
Right. Well, there are several things. One is the concept of direct primary care, and also another term I think that's analogous to it is the medical home. Mm-hmm. And again, this is a change in the reimbursement model. Essentially what it's saying is buying primary care services like you would, Netflix on a subscription basis, a monthly fee. What we've seen in private practice is that physicians who do this, one, they can get rid of a lot of billing infrastructure and become more cost efficient. Two, they get to spend more time with their patients, and that's better for the patient, and it's also psychologically better for the physician. The physician, as I say, they get to practice medicine, which is what they went to school for, not practicing paperwork. Yeah. Clearly, that model could work in a clinic, that whether it's private practice or a community health center clinic, you can use that payment model in any of these. And you can use it for any level of income, with the caveat that people who are lower income will need some help paying for it. But in terms of actually a financing and delivery model, it's much more efficient and provides better care for the patient and better satisfaction for the physician. Now, in the reconciliation bill, they finally amended, they've been pushing this for years, the health savings account legislation to say, yeah, you can pay out of a health savings account for a direct primary care arrangement without it counting against a high deductible. So that's an improvement. Again, I think about in a rural area, there will be people who are middle class, but it's not a question of income. It's a question of, is there a doc around? Right. And the facility that they may need to go to, the physician may be a community health center. So that's helpful there. We've looked at doing this in public programs. Medicare, I think there should be the ability to have Medicare Advantage direct primary care plans. I think that would be helpful, but you have to get around the fact that a physician gets penalized if they're engaging in those kind of direct financing relationships in Medicare. So the statute has to be changed. Again, you think about senior citizens in lower income senior citizens in either a rural or even an urban community using a clinic as a primary care facility. Those patients we know from the Medicare Advantage data are very attracted to Medicare Advantage plans. The other thing that I would point out, and I don't know if you're aware of it, but I've been tracking this. We've now had for a couple years an innovative insurer actually offering on the ACA exchange direct primary care health insurance coverage. Albeit in a small area. They started out in the Portland, Maine metropolitan area, expanded a little bit. Last year they were also in the Oklahoma City area. Now, for these models to work, you have a kind of chicken and egg supply and demand equation. And part of it is you have to have enough physicians in the area to make it worthwhile offering it, and enough physicians who are willing to take that kind of a payment model. So again, I think there's an area there that could be very creative for clinics.
I appreciate that. I'm actually I grew up in Maine, so I'm proud to hear that. I have a little bit of awareness of the model that you're speaking to, and Durago, which is the state, kind of credo, is the main leads the way. But I agree with you. There are some really interesting innovations, and I think more, hopefully, opportunity coming to be able to do that. I do want to pause though, and I'm going to ask you a question that's I don't know that it's tricky, but I'm curious, and because it keeps coming back to this for me, because of the patient population that we're talking about for health centers. But I think if we were to see the expansion of health centers, quite frankly, to go far beyond the 34 million patients that we're seeing and include many others outside of that, sort of 200% of federal poverty, sort of looking up and above that. But if we look at the existing patient population and you think about something like a health savings account, rural or urban, I just don't, it's sort of, do they have the resources to be able to meaningfully contribute to a health savings account? And then I think the other question is, and it's going to differ from patient to patient, but I think the other question is, do they have the education, the training, and the awareness of how to then deploy and use that health savings account in a meaningful and an effective way? Those are big questions, but I think that those are some of the realities that health centers face when we sort of look at some of these opportunities and these challenges. And so I guess my question is, like, what do you think about that?
Right. Well, I think this is not a solution for everybody, okay?
Right.
And so one of the things we recognize is there's a sort of tendency in health policy on both the left and the right for people to grab onto a silver bullet and say, aha, if we just do this, everything will be, well, no. I've never bought that, and I've always understood or tried to explain as well that different things work differently for different people depending on their circumstances. So let's take that rural example, though. What you have is, yes, you have low-income people, but you also have middle-income people, and you have people who have an employer plan, and the employer plan could offer that and fund it, as employer plans often do. So you think about a rural area. Who are the larger employers in a rural area? Well, first of all, they're government employers. So, for example, the school department, the county government, has employees. The school, district, county government. Then you think about maybe there's a large private employer. Maybe it's an agribusiness or something like that. So for those people, they are making a bit more money, and they may very well have employer-provided insurance. In fact, we know that oftentimes in families in those areas, say the father will not have an employer-provided job. Might be self-employed, might be a farmer, might be a small business person, but the wife, the husband will be that. The wife will get a job as the school teacher just to get the benefits for the family.
Yeah, well, and I want to connect a few more dots there because I think there's an interesting component. And actually, when we're talking rural, in fact, health centers are often one of the largest employers in the area. So I think it's a really interesting model. I think it's one that will be exciting to explore. It also, though, gives me pause because when I think about some of those organizations and the moment that we find ourselves in right now with just so much change, obviously reform with Medicaid, change with Medicaid, but then also the stability and the predictability of health center funding is very much in question right now. And it's worrying, right? Because nationally, about the average is 1% to 2% margins for health centers, and so when changes to Medicaid happens, that then adjusts and has the ripple effect across reimbursements. That then affects financial solvency, and like we talked about it a minute ago, that can look like dialing services back, but it can also unfortunately look like closing sites or even closing doors, and so. That brings me to questions about funding and don't we all wish we had a crystal ball? But I think in terms of the financial solvency and the future of the health center program, and even just thinking about systemic change, I'd love to hear your thoughts around investment in health centers, but also the role that they can play going forward and just the reality that they find themselves in this moment and sort of opportunities to strengthen their position and how they fit into that bigger picture.
I guess I'm looking at the way I look at it, and you may not agree, but the way I look at it is I think we've put substantial resources into standing up and supporting health centers as infrastructure. The issues are more around the ongoing payment stream of operating them. I mean, now maybe I'm willing to be educated that that's not the case, but when I look at the data, that's what I see. And so when I look at the payment streams and some of the money that's going out for different things, what I see is a system where we are paying, particularly in Medicare and Medicaid, for a hospital-centric, older status quo kind of model that is more around specialty care and procedures and less around primary care, which is what health centers are principally focused on. And in general, I think the whole system is needing to be rethought. The other piece is, though, we've oriented it towards hospitals. So the disproportionate share hospital payments are all, both in Medicare and Medicaid, they're all hospital focused. Nobody, we haven't incorporated saying, well, wait a minute, a lot of the people who we're in theory targeting, the people you mentioned below 200% of poverty, either aren't going because there's not a hospital near them, they're going to the clinic, or they should be going to the clinic because what they need can be delivered quicker, more effectively, and at lower cost in the clinic than it can be in the hospital ER that they go to. So we have to reorient those programs. The other thing that I was looking at is graduate medical education. I mean, HRSA is now helping the centers set up graduate medical education programs, right? So that's an infrastructure grant, really. But the operating grants, if you will, the operating funding is all Medicare GME money. And where do we get it? It's hospital-centric. And we wrote about this as well. Interestingly enough, I don't know how familiar we are with it, but again, this comes down to where I think clinics can work at the state level to reshape things. Are you familiar with the Medicare waiver for GME that Mike Levitt got in Utah back in the 90s?
Some. I'm sure you're more familiar than I.
Yeah, but the point is, essentially what they were proposing is, I mean, first of all, people think of these programs and say, well, Medicaid, okay, you can get waivers, the state can get waivers. The waiver statute applies across the Social Security Act, so you can get a Medicare waiver. A state could go apply for a Medicare waiver. And that's what Utah did. They said, rather than handing out on a formula this GME money, why don't we have a waiver where the federal government, give us, the state of Utah, our share of the GME money, and we will allocate it based on both the type of residencies we want to see and the location of the residencies.
Yeah.
You have a precedent for that, you see. And they set up the Utah Medical Council on Graduate Medical Education. So on the one hand, you've got HRSA funding to clinics to set up the infrastructure and get accredited and all the rest. Now go and see how can we work with HHS to redirect in a state the dollars that are going to residencies so that we're producing, say, less orthopedic surgeons and more primary care doctors and doing more of that training in rural hospitals or community health centers and less of that in just big teaching hospitals in the middle of the city.
So I couldn't agree with you more, and the timing is good. One of my next conversations is actually with one of our members who is a teaching health center and the challenges that we face with that program. But the need for more primary care trained clinicians and the opportunity to do that in the health center setting is vital. And we've already proven that it's effective. But I think what I'm hearing from you, and I love that you're calling out Utah, because Secretary Levitt, former Secretary Levitt, was a really wonderful supporter of health centers. And I think, but I think the point that you're making is right, where I think there can be a partnering of resources and sort of where it's coming from. But I think also the redirection of resources to be able to support primary care and specifically health centers. And that, it's interesting, this came up in a conversation earlier today that, the total spend across Medicaid, only 2% of it is going to health centers, in spite of how much they are doing to support beneficiaries of the program, but also save the system dollars. And so, something that came up is it doesn't have to be hugely escalation. It could be a change of 2% to 4%, but the difference that would make in terms of empowering and supporting health centers to do even more. And I think the emphasis on both whole person care and primary and preventive care shifting in that direction is not just wise, but vitally needed. And it's exciting to see. I mean, I think in the midst of a lot of change and challenges, that shift to, okay, really let's focus in on primary preventive care and where we know we're going to keep people healthy and bring them into health, but also create savings across the system. But I'd love for you to talk a little bit more about that and sort of what does it look like, or you know, where does Heritage fall in terms of that bigger investment in primary and preventive care and sort of systemic change? And you spoke to it a little bit just now, but I'm curious to hear more.
Right. Well, I guess this comes back to where we started. I try to look across silos, across the spectrum, and too often, whether people on the ground are just focused on their little niche, and it's like, I need more money for whatever it is I'm doing. You know, in Congress, it's like, well, my committee has jurisdiction over this, not over that. And you know, people are all in their silos. And so what I try to do, and what I try to encourage other people to do, is let's look cutting across this. And so when you start to look at this, and as we did with looking at funding for indigent care, we identified $45 billion in 2023, 2024, $45 billion on budget. So we're not talking about, you know, the fact that community health centers get money from, you know, reimbursement from public programs, but we're talking about the explicit programs on budget to provide indigent care. We're talking about the DISH programs in Medicare and Medicaid, of which less than $6 billion were the explicit grants to community health centers through HRSA. So when you look at that and you say, okay, that's the grants that the community health centers are getting, but it's only about $5 or $6 billion out of $45 billion that federal and state governments are spending on the theory that it's going to treat this population of indigent patients, okay? And we're setting aside the money that, you know, the centers get from reimbursement from public programs for people who are insured. I'm just focusing on the indigent care. And I'm saying, well, there is a lot of money there.
Yeah.
And every report I read from every government office that has looked into this says it's poorly targeted, it's unclear what it's doing, it's opaque, we don't know. And you know, the military has a line, and it's adopted in marketing. They call it spray and pray. We're just gonna do this untargeted. In the case of the military, you know, we'll fire off a lot of weapons. In the case of marketing, we'll just throw out a lot of ads. It's going to be untargeted. We're just going to hope for the best.
Right.
And that's how we've been funding a lot of this stuff, frankly.
So,
in the government. So our perspective is to say, before we even add more dollars, let's start and make the stuff we're spending more accountable and more targeted, right, and then see if we need more dollars.
Well, so fair to say, because I will say from an accountability perspective, you know, health centers track literally every single dollar that comes through their system. Their margins demonstrate that, you know, there's no waste. They're not putting up fountains in their foyer, so to speak.
Oh, yeah.
But so fair to say, you know, and I appreciate you calling that out, you know, there are a lot of dollars and resources that are intended to be going to indigent care and primary and preventive care. So fair to say that, you know, Heritage is of the thought that some greater percentage of that or proportion of that should be invested in health centers to really get at and have that demonstrable effect and impact of, you know, better health outcomes, cost savings to the system, you name it.
Yeah, I mean, and this is the interesting relationship as a politically conservative organization dealing with politically conservative elected officials who may not be experts in healthcare. Is the message is, don't approach this as a budget problem. That's what I said. Don't approach this as reform. In other words, too often what happens in the legislative process is, well, we'll add money here, we'll cut money here, and let people figure it out on their own. I'm saying that doesn't work. You have to approach it as reform, and then the money sorts itself out down the road. This is a perfect example of this in the DISH payment cuts to Medicaid. Okay, the left, the Democrats who enacted the ACA, right? They figured, okay, we're now going to subsidize all these people to get insurance, so hospitals won't need these disproportionate share payments anymore. We'll scale them back, right? Here we are, more than a decade later, they have not cut a single dime because the hospitals say, oh, no, the world's going to end if you do that, and they kick it down the can. And they say, okay, we'll delay cutting the dish. And the point that I made in the paper is your theory was that if you cut the money, the hospitals would figure it out and sort it out. Well, it hasn't worked. Let's reverse that thinking. Let's create a system, a reform system that says to the hospitals, you still get the money, but we're going to start by having you tell us what you did and who you treated. Mm-hmm. And you get reimbursed out of a pool and you file a claim, just like you would file a claim for private insurance or for a public program like Medicare and Medicaid. And then we'll see where we are. And then we'll see if who's right about, is there too much money, not enough money, or is it, just right Goldilocks amount?
Well, I think, so here's something I would offer just through the health center lens, because I think the accountability component is something that, one, we support, but we're already very entrenched and we have to, obviously, because of the way that our reporting system works. But I think it would be really interesting, Ed, and I wonder if this is something that Heritage has considered or just sort of on the fly what your thoughts are. If you left intact the investment, because here's the thing, health centers don't have resources the way that many hospitals do or others to cover upfront costs. And that's one of the challenges that we face in a number of different spaces. But if you were to keep intact, the existing investment or funding for health centers from within that $45 billion, but then give them access on a claims basis beyond what they're doing, and to your point, sort of provide that added accountability and sort of this is where it's going, that could work. And that could be game changing for health centers just in terms of literally all of those dollars going back into the community, into patient access, et cetera. And it also addresses something I think you said earlier, which is, or that has come up, and that is that coverage is a really important factor for the patients that we're talking about. There's interesting data, I think, that you mentioned in terms of, do patients actually access more care if they have coverage versus they don't? And that's a longer, deeper conversation. But I'm curious to hear your thoughts on that, of just sort of, okay, if we kept it intact as a baseline because health centers do need that stability and they can't cover the upfront cost, but you gave them access to a claims-based, does that align with sort of something that you're thinking?
I advocated that in the paper. In my mind, that's a political sequencing question. Okay, because the obstacle to reform is going to be the hospitals that are right now getting the money. And so what you have to do is you have to build a reform coalition that consists of the hospitals that aren't getting the money, because a lot of them are not getting the money today. They're having to eat uncompensated care, and the health centers and others who stand to benefit from it. That's how you move things politically. So the timing and the sequencing, conceptually, theoretically, yes, I would absolutely let the health centers in on the same basis, because what I'm envisioning is a system of saying, well, right, we have providers that interact with the patients who may not have insurance. Let's make sure that those providers have the ability to treat those people, and if it's not a reimbursable claim, to get some kind of compensation. So when you put it that way, it doesn't matter whether it's a hospital or a health center or whatnot. That's the ideal. How do you get there? How long does it take? How many steps? That's how the sausage is made in Congress. That's the politics of doing it.
I know. That's the city we find ourselves in, at least in this moment.
Well, you see it in state capitals, too.
Yeah.
I mean, that's one of the problems you have, for example, with Medicaid DSH, is that states will favor the publicly owned hospitals over the privately owned ones.
Right.
So, and we saw that just as an example, we saw that in Massachusetts in 2006. I remember when that reform that Romney did was primarily about Medicaid and was saying, look, instead of dumping $1.3 billion in uncompensated care funds, half of which was federal, half of which was state, on to Boston Medical and Cambridge, let's buy these people insurance. And I remember after that reform went through, I was on a panel, and the CEO of a little hospital in Concord, Massachusetts, she was on the panel as well. And she said, look, I never saw any of that money. We had to eat the uncompensated care because all the money went to the politically connected big outfits in Boston.
Well, I have lots of thoughts on that, but I don't know that we have the time to dig into it right now. We're pretty much at time, but I do just want to close with one final question for you, and that is just, what do you see the role of health centers playing in U.S. healthcare over the next decade, and sort of where do you see them fitting in the future as we're kind of working through change and reforms, and any advice?
Yeah, I think, again, the focus of health centers is primary care. We see a whole movement to refocus more attention and resources on primary care. While, for example, what Senator Kennedy, what Secretary Kennedy is doing with Make America Healthy Again, yes, there's a lot of attention around drugs, there's a lot of attention around food and additives, but when it comes down to healthcare providers, that implication is move to a more preventive model, more primary care model. Health centers are right in the middle of that. Again, if you read the academic literature, the health services research, the stuff that gets published by both in the medical journals and also in the health economics journals, there's all this stuff about we need more primary care, we need to reorient it, et cetera. So health centers, I think, are positioned to be part of what is evolving already in the system.
I love hearing that. I couldn't agree more, and I'm excited. That part makes me really excited for the future, but I really appreciate you being with us today, Ed, and for the great conversation. Would love to welcome you back for another conversation as things continue to evolve and unfold, but just
sure.
really appreciate it.
If I could say, I'm always happy to hear from folks on the ground.
Well, we have many people who can share what's happening. And I think you raised a really important point, and that is that, then this came up in a different conversation today, that, policy is often very well intended and it's backed up by data, and there's reason it's well intended, but operationally and realistically what it looks like on the ground and what folks are coping with on the ground doesn't always align with what is intended in the policy. But I think also being able to have those conversations in the field and from the ground to help inform how we craft policies, there's nothing more vital than that. So I appreciate you being willing to have those conversations. And
and I learned years ago that those of us who are trying to craft policy need to have that input. I remember a former tax counsel at Ways and Means saying, it doesn't, if you're writing some tax provision, it's got to be something that can be implemented at Treasury. You can't just, people have to be able to make it work.
Right, exactly. Well, thank you very, very much for joining us today. I really appreciate the conversation and the work that you're doing. We will absolutely welcome you back and connect you with our folks if you want to have those conversations from the field. And otherwise, thank you so much to everybody who joined us today. This is Community Health Centers Unfiltered, and we look forward to you joining us for a new conversation the next time. Thanks, everybody.